When pregnancy is desired, success is expected immediately. However, under age 35, the normal chance of conceiving per month of trying is only 20%. For women over 40, it's 5%. Therefore, reproduction is largely an age-related phenomenon. Also, weight, smoking, and other lifestyle variables also play a significant role. Fundamentally, it comes down to one of two things. It's either seed or soil. That is, it's either the embryo or it's the womb, the lining of the uterus, the implantation. The embryo is a composite of amalgamation, of course, male sperm and a female egg, and its own unique contribution. Implantation, however, that implies what is happening with that seed, that is the embryo, implanting into the uterus. A mock cycle is useful in determining the implantation window of that embryo. So fundamentally it comes down to seed or soil, and with the embryo, the state-of-the-art in this field today is pre-implantation genetic testing. That is, do we have an embryo with the correct number of chromosomes? Now, just because you have an embryo with the correct number of chromosomes doesn't mean you get a baby, but it does increase the potential to have a baby. So once one has an embryo with the correct number of chromosomes, the next step, the other side of the coin, is implantation and determining the correct timing of that implantation. Classically, implantation occurs roughly 6 days after the body makes or is administered progesterone. What happens in the lining of the uterus, there's certain adhesion molecules, sticky molecules if you will, that appear in the lining of the uterus in response to that progesterone. And that's generally true for the great majority of women, but there's a minority of folks where the implantation window may be shifted 12, 24, or even more hours. So that would render implantation less likely to occur, and if it does occur, perhaps more likely to end in an early pregnancy loss. So a mock cycle is used to determine the precise timing of when that embryo should go back. How it works is either using a natural cycle or an estrogen prime cycle or even an ovulation induction cycle. It's administered to the woman, and then what happens over time, estrogen levels are measured potentially, but most likely progesterone, and then an ultrasound to look at the thickness, the uterine lining thickness. When appropriate amount of progesterone, that is a lack of progesterone, occurs, because high levels of progesterone could block implantation initially. So you want to time the giving of the progesterone. So when the conditions are right, progesterone is administered, and then 6 days following administration of progesterone, an endometrial biopsy is performed, which has some minimal discomfort that can largely be obviated by 2 extra strength Tylenol. You don't want to take NSAIDs, ibuprofen, because they may have something to do with prostaglandins involved in implantation. But 2 extra strength Tylenol taken an hour before generally works for most people. The endometrial biopsy can take as little as 30 seconds. Then what happens? The woman stops her estrogen, if she was on that before, stops the progesterone, she gets a period, and we wait for the results for the biopsy to return. And we get a report back saying that she is either receptive, pre or post receptive, and by how many hours? 12, 24 or more. And using that information in a subsequent frozen embryo transfer cycle, an embryo with the correct number of chromosomes can have as high as an 80% chance of an ongoing pregnancy if that biopsy was determined to be pre-receptive, and now the clinician knows that and can treat it. Ongoing pregnancy rates are stellar.